be presenting the next topic. امبارح ناقشنا بشكل أساسي ال ARDS بمرضى ال ICU. I'll be presenting a more specific discussion about ARDS in COVID-19 patients. I think it's a very relevant topic للعديد من الأطباء. In the discussion today, مرة أخرى الدكتور فادي حامد. Discussion today راح نناقش بشكل أساسي the practical aspect على severe pneumonia and ARDS in COVID-19. نتحدث بشكل أكثر على حاليا what we know as clinical guidelines for COVID-19 in the ICU, and then we'll talk about the management and standard of care for patients with COVID-19, severe pneumonia and ARDS. So simply speaking, لو نحكي بشكل عام معظم الداتا اللي بنعرفها هلا more than 80 to 85% من المرضى اللي عندهم COVID-19 are actually either asymptomatic or have a very mild disease, which leave us still with a good percentage ما بين 10 إلى 15% من المرضى they may present with either pneumonia, severe pneumonia, or being critically ill with ARDS and multi-organ failure. In general برضو من هدول ال 10 إلى 15% we usually would encounter 1 to 5% of patients who are critically ill بيكون عندهم ARDS picture أو severe pneumonia. معلومة كتير مهمة أذكرها, and this is you will notice it to كل زملائنا سواء في أي مكان بالعالم they follow the patient with COVID-19, you will be always seeing that the patients اللي ببلش عندهم critical illness, usually it happens almost 5 to 7 days from the initial onset of symptoms. So you'll see this very common in the patients. He gets the symptoms and he's fine, بيكون on having intermittent fever, ممكن عنده mild symptoms of cough, nose congestion. Then usually a critical point راح تلاحظوها. On day 5 to day 7, this is the period where most of the symptoms deteriorate for those who decide to deteriorate. في عندك 85% will still have a mild disease, will never progress. بس عندك 1 to 5% of those patients on day 5 to day 7, you can see the median is almost 6.5 days min onset of symptoms where they will go and develop critical illness. So if you're admitting somebody عندك للطابق in the acute floor, please keep a close eyes on when the symptoms started. Be very careful about the patients who are reaching day 5 to day 7, day 8 with onset of symptoms, لأنه هاي هي المرحلة اللي most of the patients who decide to deteriorate will deteriorate. I've rarely seen anybody who has been stable for day 10 or day 11 or day 12 where they progressed into severe pneumonia after that point. So how do we find the illness لعنا المرضى اللي عندهم COVID-19? So if you look at this, symptoms, عنا المرضى بتقسموا ل asymptomatic or mild disease اللي حكينا عنهم, these are 80 to 85%. عندنا المرضى اللي بيكون عندهم النيمونيا أو الالتهاب الرئوي, these are people عندهم بيكون cough, shortness of breath, fever, symptoms of pneumonia. عندهم symptoms مع radiographic changes, so الchest x-ray بتكون abnormal أو زي CT scan, but هدول المرضى عندهم O2 saturation is more than 94% in room air. بعدين في عندك المرضى المتطورين أكثر اللي هم بنسميهم severe pneumonia أو إن other terminology بنسميهم severe acute respiratory infection أو SARI. هدول المرضى راح يكون عندهم symptoms of pneumonia, يكون عندهم radiographic changes على الإكس-راي, plus you will see they'll be tachypneic, they'll be in distress, وهدول بيكونوا hypoxic. لما تقيس الأكسجين عندهم بيكون أقل من 94% on room air. And these are the ones that's usually you have a high chance to rapidly progress into more ARDS picture. So this is حكينا امبارح بس برضو بأكد عليه مرة ثانية. You can see the X-ray is not clearly visible, but you can see there's bilateral infiltrate. قلنا المريض بيكون عنده symptoms ARDS within 1 week of the onset of symptoms. وزي ما حكينا امبارح تقسيمها using the PF ratio للمريض into mild, moderate, and severe ARDS. So المعلومة المهمة اللي من ما بلش البانديميك من شهر 12 أو 1 if you want to talk about it is how to supplement oxygen therapy لهدول المرضى. What's our target? Remember, if you're more than 94%, you're good. You don't need to do any supplemental oxygen. The idea of supplemental oxygen starts when your saturation on room air is below 94 to 92%. This is when you start your strategic plan to supply them by oxygen. حكينا methods of oxygen delivery امبارح, so you go with a nasal cannula, venturi mask, you go with a non-rebreather mask. The idea in this situation is you want to bring the oxygen saturation up to maintain a saturation above 92 to 94%. And مرة أخرى هدول المرضى, the one that you should be keeping a very close eye monitoring them. مرة أخرى, if you have somebody in the hospital, is day 10 of his symptoms, he's improving, he's stable, his fever is subsiding, this guy is unlikely to progress compared to somebody who's day 3, febrile, have respiratory symptoms, and showing more signs of respiratory distress. You will see this guy likely to progress more into respiratory failure. مهمة جدا المعلومات اللي بدنا إياها. Who are the patients اللي بدخلوا عندك على المستشفى with pneumonia or with mild even symptoms of pneumonia or with severe pneumonia that are at a higher risk to deteriorate? What we know so far, أهم factor is the age. One of the most important factors is age. Actually, the studies that عملوها بإيطالي from Milan and the Lombardy area, most of their mortality they had were for patients who are more than 70 years old. Actually, their mortality was 80% بالمرضى اللي عمرهم 70 فما فوق. The older you are, the higher risk you are of developing, severe pneumonia. وجود other comorbidities, we have seen endless number of patients who has comorbidities, mainly diabetes, hypertension, chronic lung disease. These are very high-risk patients to develop, worsening severe pneumonia and ARDS. طبعا, if you have active malignancy, chronic kidney disease patients, and definitely active smoker. Morbidly obese patients, more and more data about it. We know that from the influenza pandemic. And بالتأكيد أي مريض who is immune compromised سواء because عامل solid organ transplant زراعة أو he's on immune suppression لأي other connective tissue disease or any other medical problem. So those guys, I would keep a close eye on them. Actually, as part of our criteria بالمستشفى كان عندنا, if you have age more than 65 or you have more than the 2 comorbid illnesses, diabetes, hypertension, or having 2 of them or more, you even coming with the symptoms to the ED with mild symptoms, you won't go home on home isolation. We prefer them to be admitted to be monitored in a hospital setting if you have the capacity to do that, لأنه هدول المرضى are the highest risk to deteriorate rapidly. Simply, برضو عندنا certain lab tests that were shown if you do it again in a COVID-19 patients. Again, you can see the list is big, but most of them are very simple blood tests that almost any lab can have it. Lymphopenia, thrombocytopenia, deranged liver function test, LDH, inflammatory markers. You'll be surprised how much elevated CRP and ferritin will be on the patients, mainly when they go into what we call the cytokine release syndrome or the cytokine storm. نحكي عنها بعد شوي. D-dimer, a very important factor. You will see it also, and I think my colleagues will talk about it in the venous thromboembolic disease lecture. Is عندك elevated troponin. We know some patients come with cardiac abnormality. بالتأكيد having acute kidney injury is also another risk factor. You can see these are very simple blood tests that most of the labs can do. CBC with differential liver function test, a CRP in there, and then can be an indicator of who can develop into worsening pneumonia and ARDS. So to talk more and more about the patients who go into your severe pneumonia and mild to moderate ARDS before they go to the intubation and mechanical ventilation, you can see that the modalities that we can provide. We know there is حكينا امبارح عن high flow oxygen or high flow nasal cannula. We have the non-invasive pulse pressure ventilation, and then you have the invasive mechanical ventilation. A lot of data happening, a lot of discussion. According to the most recent guidelines that has been coming, from the COVID-19 in severe pneumonia and mild to moderate ARDS, it's highly recommended if you need to move from normal oxygen to ventilator mask to a higher level of oxygen delivery is to use high flow nasal cannula. I know it's hard in Jordan. I know the equipment is not much available بكل المستشفيات بالعدد اللي ممكن تحتاجها, لكن somebody who's maintaining a saturation of 92 to 94 on 4 liter doesn't need a high flow nasal cannula. بينما somebody who is saturating 80% على non-rebreather mask, it's clearly this guy you will need to put him on high flow nasal cannula. هلا as a machine امبارح ذكروا زملائنا, it can provide up to 60 liter a minute, up to 100% saturation. الفكرة الأساسية when you put the patient on high flow nasal cannula, you have to be also very careful لانه في انتشار كثير بيكون للرذاذ للمرضى لما تحطهم على high flow nasal cannula. So actually if you're not in a negative pressure room and you're in a droplet precaution او حتى if you're in a negative pressure room, we have recommended المرضى اللي عندهم high flow nasal cannula انهم نحط لهم السيرجيكال ماسك while they're in the room with the healthcare provider. اذا هو بالغرفه لحاله usually we did not recommend that, بس بالفتره اللي ندخل عليها to take care of him. هاي معلومه مهمه جدا للنرسات كمان الموجودين معنا لفنيي التنفس. It's safe to use the machine, but at the same time we would recommend to put a surgical mask للمريض إضافة your own protection methods اللي بتستعملها خلال وجودك في هاي الغرفة. وإحنا عندنا كل المعلومات عن الهاي فلو. We know in general سواء بالكوفيد و non-COVID, it's very helpful technique and strategy صراحة to help the patients and proceed to mechanical ventilations. And we saw it how much it worked relatively in most of those patients. They'll be safe, able to breathe, able to maintain a saturation, and really prevent them from going into intubation and mechanical ventilation. Another strategy is أكيد سامعين فيها بنسميه الاسم التجاري BiPAP أو non-invasive ventilation. Most of the data still recommend to go with high flow rather than non-invasive ventilation. In Italy, they use a lot the CPAP helmet machine. أكيد شفتوها اللي هي helmet تنحط على راس المريض. It goes in a CPAP methods. We still think, according to the data, سواء مع الكوفيد and non-COVID, high flow is a better strategy, but non-invasive mechanical ventilation can be used. إذا ما عندك high flow, can be used for a brief period of patients, you know, while if they fail, بالhigh flow بتنتقل من الhigh flow لBiPAP, although this strategy almost failed, and we would recommend if you fail high flow, maybe you can try an hour or two on BiPAP. Don't delay it more لأنه we know إنه في كتير delay للintubation بيصير للمرضى على الBiPAP. مرة أخرى, if you're in BiPAP, try to use the full face BiPAP أو the nasal mask to be avoided لأنه برضه ما بدك الرذاذ يتطاير بالغرفة. If you don't have high flow and you only have BiPAP, non-invasive, go with that methodology as a way to help the patient. So if you want to summarize high flow versus nasal cannula, we know the current recommendation is to use high flow over the non-invasive ventilation if both modalities are available. إذا ما عندك المachine to provide high flow, go and try non-invasive ventilation in those patients and hopefully it works. النصيحة الأساسية, don't delay intubation in those patients. المريض نفسه within an hour or 2 or 4 hours, he will declare himself. If you're going with an O2 saturation from 90 to 80 to 70 وبنفس الوقت عم بتزيد ال FiO2 30 40 50 60 100%, it's likely that this patient is failing. So you look at the number, you look at the patient, at the same time you don't delay intubation. But if you can prevent intubation and mechanical ventilation, that would be better لأنه once we put them on mechanical ventilation, you'll see a long duration of mechanically ventilated. There's exposure, there's sedation. So the turnover of beds will be limited with mechanical ventilation if they are stable on high flow. And we have kept patients on high flow for 5 or 6 or 10 days, and you'll see them turning the corner and improving. Again, as long as they are not showing any signs of severe distress and worsening. You have seen that most likely non-stop people on high flow 100%, and they're texting on their phone, and the saturation is 92%. So those patients, I would not worry. Give them time and they will improve. Once you start seeing them deteriorating, you move to the next step. So this is kind of strategic workflow احنا عملناه عندنا بالمستشفى. So you start here with the SARI. If your sat is less than 94%, you look at the oxygen. If you maintain a saturation more than 94, 98 with that oxygen therapy, this is great. You keep observing them. Now, if you start to deteriorate, the rate is going up, the sat is going down, we do x-rays, we do blood gases, and then you do the trials of high flow or BiPAP according to you, and you follow them very closely. Usually the patient with high flow or BiPAP should be monitored in either a step-down unit, high dependency unit, or if you have the capacity in your ICU. A decision to intubate is very important. I can tell you a lot of time when we decided to intubate, we had a couple of group discussion. Some patients clear shortcut, واضح بنسبة 1,000,000%, you have to intubate him. He's breathing 40, له 6 ساعات at high flow, his saturation is 70%, his distress, the PO2 على blood gas is 50, the PF ratio is 40 or 50. This is no doubt. There is some patients you always will be in doubt. So don't be afraid to ask a colleague to discuss it among yourself as a team. One discussion will be the code status. Do you need even to intubate that patient? That's a separate discussion. But sometimes there's those gray zone in which you have to discuss it as a group and decide, should you wait? Should you try different modality? And talk with the patient. Sometimes the patients will give you some advice about also, does he feel well? Is he deteriorating? So a lot of things happen together. But مرة أخرى, don't delay intubation. But at the same time, what we learned clearly, and I would advise you $1,000,000%, and I take responsibility with that with all my colleagues, do not do early intubation. We know that early intubation does not work on those patients if you are able to provide them with the right appropriate oxygenation, saturation, medical management without intubation. Most of the data in Italy, why patients died a lot, either because they were not intubated because they're made comfort care, or we know now the early intubation may not help those patients. So امبارح حكينا بالموضوع بشكل أساسي. I will talk about it simply. حكينا عن intubations, mechanical ventilation. We have a full lecture by Dr. Omar Al-Durra. He will focus more about that topic in it. We also again and again talked about the predicted body weight to use in those patients, 6 ml per kg of predicted body weight. ركزنا بشكل أساس to maintain a plateau pressure below 30. ومرة أخرى, we're happy with the saturation between 88 to 92%, or a PO2 على blood gas 55 to 80. We talked again, make sure you have a central line or arterial line in severe ARDS. They'll be intubated, they'll be sedated, they'll be on pressors. We talked about the deep sedation. We had a very nice lecture yesterday. Sedate them, achieve, good sedation with medication like propofol, fentanyl. Very frequently, we saw it in young population who were intubated. They required, benzodiazepines, so we used midazolam. You will see once the volume goes up more and more in your ICU, you will move for the non-traditional methods. We used morphine more, we used hydromorphone more, and the fentanyl will become short. Propofol may become short, so you may need to use more midazolam, lorazepams, more benzodiazepines. So you'll need to adjust to what you will have into your ICU for sedation. ومعلومة مهمة, you need to make sure they're sedated well so that they will have a good synchrony مع ventilator. Again, we focused yesterday on conservative fluid management, but a very valid point, and Dr. Nizar will talk about the acute kidney injury. A lot of those patients come to you already dehydrated from the persistent fever. So be careful about what you use from your diuretics and fluid management. But again, in an absence of acute kidney injury, pre-renal azotemia, try to maintain a negative balance with conservative fluid management. Again, the younger they are, the more severe ARDS, you will move more and more to neuromuscular blockade agents to be used on those patients. You may need to paralyze them either by pushes of certain paralytics or as continuous infusion. A very valid point, you will see it like working like magic in those patients with severe ARDS, is proning and proning and proning. I'm not sure إذا المستشفيات بالأردن مهيئة لنعمل the prone position. If you want to invest in something in patients with severe ARDS who are not responding to sedation, paralytics, low tidal volume, plateau pressure below 30, negative balance, please prone those patients. We have a full lectures following up about proning. It's really one of the perfect intervention that can save life in our patients. I'll show you our data at the end of this topic. Proning saves lives. Usually, if you do not improve within 24 to 48 hours of the interventions we talked about, even we did sometimes within 12 hours of lacking of response to the intervention اللي حكيتها, proning the patients would be a very valid technique strategy to be done in those patients. Usually we prone to 12 to 16 hours. Again, there's a full lectures about it. And again, there's certain parameters that you can do using the PF ratio and the PEEP and the FiO2. But again and again, I would recommend you to use the proning, and my colleague will talk in more detail about it. I don't know برضه إذا البولي vasodilator متوفرة بالأردن, but using inhaled nitric oxide has been very helpful as a temporary measurements in those patients. It would help you a lot in the severe ARDS. Usually as a salvage therapy, we use inhaled nitric oxide plus proning in a lot of patients with severe ARDS, and it does help. Usually if it does not show response with improving gas exchange within 24 to 48 hours, usually we would stop them. I know there is more and more data suggesting inhaled nitric oxide as a pulmonary vasodilator could be associated with more acute kidney injury. So that's why we give it a try for 24 and 48 hours, not more than that. More and more data, Akid Sam'in, right now we know all the data about the systemic corticosteroids. We're talking specifically على المرضى اللي عندهم COVID-19. Corticosteroid and ARDS has always been, difficult topic. There's a lot of, pros and cons about it. But if you look at, recovery trial that was published in UK, apparently patients with COVID-19 who are hypoxic with severe pneumonia or with ARDS did have improvement mortality with using dexamethasone, 6 milligram daily, or what's equivalent for it in a form of methylprednisone in there. One factors I need to emphasize about it, المرضى اللي عندكم بالICU with COVID-19 who are intubated or even on high flow and BiPAP, again and again, be careful of the aerosolization. Although it's not much, we did not do any bronchoscopy on any intubated patient who is confirmed COVID-19 if there is no indication. Bronchoscopy is an aerosol generating procedure. If you have a definite diagnosis and you have a COVID positive and there's no other possible etiology for other diseases, we would not go ahead and proceed with bronchoscopy. On the other hand, we had a COVID pandemic, right? We had a patient who was 40 years old who came with fever, shortness of breath, ARDS, was intubated. His COVID was negative 1, 2, 3, 4 times. So with that, we did a bronchoscopy, and it helped us to diagnose an alternative disease. It was eosinophilic pneumonia. So still think that there's other etiology, but the first, we ruled out COVID multiple times, and then we did the bronchoscopy. In a confirmed COVID, we did not go for a bronchoscopy for unnecessary reason, just to confirm a diagnosis that's already confirmed. So if it would not affect your management, I would not recommend bronchoscopy. الأمر الثاني, we did not use any inhaled nebulizer medication in the ICU. So the nebulizer, Atrovent or Combivent or any form of bronchodilator, we did not use a nebulizer. We rather use them in a compressed devices. This is a very valid point. Even حتى بالطوارئ بالemergency department, حتى بالطابق للمرضى مرة أخرى اللي عندهم COVID, we did not use the nebulization methods because it's a high risk of aerosolization. And then we had different strategies to use that, either with a spacer, out to move them to the meter dose inhaler. Out bil ICU, we use the more practical aspects of there. DVT prophylaxis, as I said, you should have all your patients on DVT prophylaxis. There's a full lectures about it. Blood glucose target, we had a 140 to 180, hemoglobin of 7, and at the same time, enteral feeding is standard approach and not TPN. You will see a lot of patients who will develop, secondary sepsis, septic shock, and VAP pneumonia. So be careful about those patients. Have early identification, early intervention, fluid pressors, blood cultures, sputum cultures, broad-spectrum antibiotic. We did not see a lot of patients going into secondary pneumonia, secondary infection. The rate is low, but the more they're in the ICU, the access they have, the lines, they're still prone for infection. Again, vasopressors used. We talked about it yesterday. Stress dose steroid if you go into shock. Again, we're talking about shock phase now, not about the patients with COVID dexamethasone pathway. My last 2 slides. So we know there's a lot of patients who have associated complication. غير sepsis with septic shock, with ventilator-associated pneumonia. Few patients will develop cardiac injury. We have seen myocarditis mainly with a low EF. So doing an echo sometimes would be helpful in those patients to assess them. Acute kidney injury, Dr. Nizar has a full lectures about it, but it ranges between 15 up to 80%. So the range is very wide about it. There's a full lectures about hypercoagulable status and thromboembolic events. And then the cytokine storm, we saw a lot of patients on day 5 and 7 goes into complete, vasoplegic shock with high, inflammatory marker, refractory shock, and then evidence of high CRP, ferritin, interleukin-6 were high in those patients. So you'll see a lot of, inflammatory response happening in absence of sepsis and septic shock. And this also will be discussed in the treatment aspects later on. Just my last 2 slides about extubation. So we follow the standard protocol. We prefer to extubate those patients into an airborne isolation room. If you don't have the airborne isolation room or the negative pressure room, We brought what we call a HEPA filter, which is a big machine. It's a portable one. You keep it in that room. And actually, one method we use during extubation is to have limited number of staff into the room. كأن واحد أو اثنين داخل الغرفة. Usually the respiratory therapist and the doctor. We did all the standard protocol. And actually, one idea was once you're ready to extubate, the patient is following all the standards for spontaneous breathing trials and ready to be extubated. We put the ventilator off during that method عشان تخفف الjet of airflow, and then we extubate the patients, and then we monitor him, and we keep that room with nobody inside it as long as the patient is stable for 15 minutes to keep time for the air to circulate into that negative pressure room. I'm not going to talk about the treatment. There's a full lectures about it by Dr. Faris Masannat. So this is just what we talk, with some options, but I'm not going to touch base about it. Just in the last 30 seconds, just to show you, this is the data we published for our first 55 patients compared to different studies from Seattle, Atlanta, the US, Italy, and Spain. You can still see, there's always going to be a percentage of patients in your ICU. Prone position, you can see it's always being used at a different percentage. The only thing I want to show you that once you're your ICU stay is not like the usual COVID, the usual ARDS 3, 4, 5 days. You're talking about 10 days to 2 weeks minimum of ICU stay. So, once you're intubated and mechanically ventilated, you're going to stay in the ICU for a while. And that's why you have to wisely decide about the intubation process and to do your strategic process. Another very important factor is look at the survival rate, and death. So we're talking about the death in the ICU. For our 55 patients, we only had 22 deaths. There was 31% death. 26. So the death is not like people are talking about. Yes, Italy can يحكوا عن 4 to 50. Some centers in the US are talking about 80% mortality. It's not anymore. حتى we talk with our colleagues بالسعودية بدول أخرى. The mortality rate right now is acceptable to be not more than 25% on mechanically ventilated patients. So it's not a high-risk mortality anymore if you follow the usual standard treatment therapy for ARDS. This is just the slide about the mortality rate that you can talk percentage of who gets mechanically ventilated, the mortality rate. Again, 22%, 26%, 33%, 31%. So again and again, not everybody who goes on mechanical ventilation should or expected to die. Rather, the majority should be extubated and be able to be discharged. So for the sake of time, I'll stop here and see if we have any questions that we have regarding the topic. I'm going to unmute Dr. Ahmad because he's the one who was supposed to follow on any questions.
يعطيك العافية دكتور فادي. شكرا على المحاضرة القيمة. في كم من سؤال بس قبل ما نبلش في سؤالين عن البرونينج راح أتركهم لعلي زايد إن شاء الله محاضرته.
Full lecture Dr. Ahmad. We have a full lecture about it.
اوكي. في اول سؤال كان في اي ستدي على الريسك فاكتورز في اليونج هيلثي سموكرز؟
Not much. So again, smoker as itself is a risk factor, but the younger you are, the less the chance of progressing into disease. But I can tell you, from dealing with more than 250 patients in our ICU, we have seen ARDS at the age of 20, 30, 40, 50, 60. So age matters. Yes, the older you are, the more the chance of getting worse. But young really still develop bad pneumonia, bad ARDS, and we have lost young people with no other comorbidities at age of 30 and 40.
اوكي. السؤال الثاني فهمنا انه we prioritize الهاي فلو نيزل كانيولا على النون انفيزيف فنتيليتر if we have both. هاي الهاي ريكومنديشن بتفرق اذا المريض COPD او obstructive sleep apnea؟
Great question. So there's still, the data about the use of non-invasive ventilation in patients with COVID-19, with sleep apnea, or with COPD, or with, form of cardiogenic pulmonary edema. So in those patients, I would still, favor high flow initially, but have a higher threshold to use COPD, to use the BiPAP in them compared to somebody with no other risk factors like those. Hypercapnic failure, definitely. We prefer to go directly sometimes with BiPAP rather than high flow.
اوكي. في سؤال ان شاء الله اكون فاهمه صح. اذا في patient كان ستيبل على هاي فلو نيزل كانيولا او نون انفيزيف فنتليتر وانت يو داون ستيب هيم تو فنتوري ماسك، اذا صار في دي ساتنج ترجع تاني على الهاي فلو نيزل كانيولا ولا يو جو فور انتوبيشن؟
It depends. So again, this is I would still go to high flow. Remember, you'll see a lot of those patients fluctuating a lot. One day is a good day, the other day is a bad day. But I would still, if there's no signs of massive deterioration, I would try him again high flow before proceeding with intubation and mechanical ventilation. My take-home message is, again, as much as we like high flow and BiPAP, please do not delay intubation. But at the same time, if you can manage safely with them, you will see that you will protect your patients. It will be better for him, and also less complication for the patients if he gets intubated and mechanically ventilated.
اوكي شكرا. واخر سؤال اذا في مجال، اللارج تايدال فوليوم جنريتد على النون انفيزيف، هل هذا ديسيفنج؟ واذا